So let's start. These are some of my learning objectives. I'll go over Parkinson's disease, the prevalence, motor, non-motor features, risk factors, and then management. You guys, a lot of you must have experienced this when your doctor tell you those 4 words that you have Parkinson's disease. As my mentor, Dr. Oken, used to say that it pierces the heart and drains the dream out of their lives. Because when you ask the patient what exactly this means, Parkinson's disease, they always confuse it with Lou Gehrig's disease, Alzheimer's disease, but it is not. It's quite livable and treatable disease, and that would be our prime objective of all the speaker will tell you about that, how livable and treatable this disease is. Some of the cardinal features, motor features of Parkinson's disease, we learn it in med school, a trap. It's like that patient with Parkinson's disease, they are trapped. T stands for tremor, rigidity, akinesia, and postural instability. The tremor in Parkinson's disease is very classic. It's a pill-rolling tremor. We call it a pill-rolling tremor. The thumb usually roll over the index finger. Usually we see it asymmetric, mean in one hand, but it can be seen in jaw. Leg tremor is also very classic for Parkinson's disease. Head tremor is not classic. Some research say that if you find head tremor, you can challenge even the diagnosis. Important thing is 1 in 5 patients with Parkinson's disease that they do not have tremor. And hence the confusion arises that, hey, doc, I don't have any shakes. So 1 in 5 patients with Parkinson's disease, they don't have shake. Then comes the R stands for rigidity, means stiffness. Stiffness, axially we call it, axially and appendicular in arms, legs. And usually patient, when they start having those stiffness, they end up in rheumatological clinic or orthopedic clinic with stiff shoulder and stiff legs and stiff hip. Then the most important one is akinesia, bradykinesia. We give those fancy names just to build more for those things. The simple thing is, the meaning of that is slowness of movement. You might have seen your doctor ask you to do those movements in finger, hand, leg movement, and walk you around. And it must be differentiated from normal aging, the slowness that we see in old age people. And P stands for postural instability. We have a good lecture by Dr. Siddiqui on that. This is the typical posture with Parkinson's disease. They have what we call poker face, stoop posture. It's just like their center of gravity is 1 point ahead of them. And they try to catch it. And meanwhile, trying to catching it, they usually tend to fall. Same is true for the retropulsion. You must have seen your doctor pulls you. And why is that important? Just to check your postural instability. Because sometimes patients usually try to lift things up and they cannot prevent going backward. And you can work with therapists and it respond really well. And then late stage, you guys can also experience freezing of gait. This is a very important slide. Different PD stages. The one that a lot of researchers has been working on is finding a biomarker, preclinical stage. If we can find something, some biomarker. What is a biomarker? Biomarker, you must have seen it. When you have high blood pressure, you go to doctor, they check your blood pressure. Diabetes, they check blood sugar to monitor, to diagnose, and then treat you accordingly. We do not have a biomarker, but this PPMI study from Michael J. Fox Foundation, they've been working on it, whether if we can find a blood test or CSF, tear, any marker, any imaging marker, any other clinical marker that we can test patient for and diagnose them before their symptoms starts. There are certain genetic factors also there, LLRK, GBA, genetic susceptibility, and there have been a lot of research going on. Stay tuned for this PPMI study. It's in the final stages, and we will have the results soon with us. Then comes the prodromal stage, what we call prodromal. Means that it comes prior to the appearance of motor symptoms. What are they? Loss of sense of smell, hyposmia, anosmia, REM behavior disorder, constipation, and depression. People with Parkinson's disease or who are prone to Parkinson's disease, they develop these features sometime years, sometime decade before the appearance of motor symptoms. They lose their sense of smell. RBD, REM behavior disorder, means they act out their dreams. They have vivid dreams and act out dreams, throwing punches, kick their spouses, and fell off the bed sometime. Constipation, and then mood problem. But if you guys can see that, it's very common. 63, 65 million people in the US have constipation, right? So people can freak out, but it's just the combination of those things. And if we can find any biomarker and combine it with these, and we can have some diagnostic criteria at the end. Then PD early features, as I mentioned, slowness of movement, stiffness, tremor, and in advanced stage, dyskinesia, those abnormal movements. You guys must have seen Michael J. Fox when he was testifying in front of Congress. He has those abnormal movements. That is called dyskinesia. Memory problem and autonomic disturbances also comes into picture later on. This is a busy slide, but a very important one, and more than half of our time is spent on this in clinic when we are evaluating you guys. So in the center is Parkinson's disease, whether it's tremor predominant or PIGD, means postural instability gait disorder. I mentioned that not everyone with Parkinson's disease, they have shakes. So they could have this postural instability gait disorder. But one of the other big group is this atypical Parkinsonism. We call it atypical because they are atypical. That means they don't respond that much robustly to the medication. And prognosis is also different than typical Parkinson's disease. Among this group, MSA means multiple system atrophy. Other systems are involved. This group is also called Parkinsonism plus syndrome. Parkinson plus something else. So in MSA, you guys can see a lot of autonomic features, mean bladder issues, incontinence, retention, frequency, drop in blood pressure, GI issues, and a lot of other autonomic features. PSP means progressive supranuclear palsy. This is the atypical Parkinsonism. When the disease starts with falls, and their falls are different than a typical Parkinson's disease fall. They have a lot of balance issues, and eye abnormalities mean they cannot move their eyes up and down. Then it should be CBS, corticobasal syndrome. They have a lot of cognitive impairment, and they lose their skill functioning. Moving arm, and they have sometimes developed this alien limb phenomena, along with a lot of other movement disorder, myoclonus, dystonia, and those other additional features. Dementia with Lewy body or Lewy body, Robin Williams was the prime example of that. Dementia with Lewy body. So they develop dementia right at the onset or somewhere the time period when their motor symptom starts. And then, of course, we have to differentiate it from other movement disorder like essential tremor, dementia. But on the left side of screen, you guys can see these the different group. This is what we call secondary Parkinsonism. Secondary due to some reason. Drugs, antipsychotic medication, anti-nausea medication like metoclopramide, compazine, metabolic, and inborn errors of metabolism. In kids, you can see this, toxin, trauma, punch drunk, post-encephalitic Parkinsonism, that was at the earlier part of last century. With flu, people develop features of Parkinsonism. Brain tumor, and then vascular Parkinsonism means due to stroke or those vessel changes. Why this group is so important? Because first of all, we can prognosticate it. If you have typical Parkinson disease, it will respond really well to medication, kind of normal lifespan. You will have shake, other problem, but we can give you different therapies, medical therapies, surgical therapies. But if it is those other atypical Parkinsonism, prognosis is a bit different, a steeper decline in clinical features. And if it is secondary Parkinsonism, get rid of the offending agent, right? Some people are on those antipsychotic, get rid of those medication, and the problem would be fixed. And same is true when you guys are hospitalized or go to hospital. You can discuss with your doctor there that, hey, this medication that you are giving me, is it good for my Parkinson disease or not? Because it can further hurt your Parkinson disease. When you come to a clinic, people are under the impression that, Parkinson disease, there would be $1 million test or something like that the doctor will give me, but it's a clinical diagnosis. The doctor will talk to you, examine you, and then will tell you whether you have Parkinson disease or not. In rare cases, we can utilize this scan. It is called DET, dopamine transporter scan. Anyone heard about that? You can raise your hand. Dopamine transporter scan, DET scan. It's not necessary for the diagnosis, but sometimes the tremor could be confusing with other neurological disorder like tremor from essential tremor, those familial tremor. In that case, it's FDA approved. We can do that, and you guys can see if it is a period, there is abnormality in those factories or in those circuits. But if it is a coma shape, means that the integrity of that circuit is intact. Sometimes it can be utilized for drug-induced Parkinsonism. Patient, you get rid of the offending agent, but still they have features. Sometimes I utilize it, but not for every patient with Parkinson's disease, because sometimes it can confuse the picture further. You guys will have the typical Parkinson's disease, and the scan would be normal. That is called scan without evidence of dopaminergic deficiency, SWEDS. So not in every case we do that scan. So to scan or not to scan, that is the question. Then types of Parkinson's disease, I mentioned, tremor predominant, PIGD form, young onset YOPD, young onset Parkinson's disease, and LOPD means late onset Parkinson's disease. Young onset is usually between 20 to 40 years of age, and the typical age range is usually in 60s. 50s to 70s, 62 is the average that people usually develop this disease. James Parkinson described this disease in 1817. So last year we celebrated the 200th anniversary. And he saw 6 patients, 3 on the streets of London and 3 in his clinic. So just by observation, he described those patients, and he's right about the motor symptoms. The only thing he was not right about is the non-motor features. Parkinson, you guys have heard about the alpha-synuclein and Lewy body? Any one of you can raise your hands? This is the protein which is deposited in patient with Parkinson disease. We call it alpha-synuclein. Just like in Alzheimer's disease, there is a different protein that is deposited, amyloid and tau protein. In Parkinson disease, it's alpha-synuclein. And when it clumps up, and it's a normal protein. Everyone has this protein, but when it gets misfolded, it clumps up and forms this sticky protein, which deposits in the cell and so the cell cannot talk to each other then, right? Because there is this abnormal protein there. And this is that factory which produces dopamine. I'll discuss what is dopamine, the chemical responsible for Parkinson's disease. So this is called substantia nigra. Nigra means black. It's black in color normally. So when there is a cell loss there, the color changes to white. Bragg hypothesis. This is a neuropathologist, a German neuropathologist who described this hypothesis, how Parkinson's disease protein spread, or the clinical feature and what's the correlation with those proteins. So his hypothesis that it starts in the gut. The protein develops, this alpha-synuclein, it develops in the gut. That's why people develop constipation. There is some evidence that people who underwent vagotomy in the past, good old days, that was used for stomach ulcer. Those patients who underwent vagotomy, less risk of Parkinson's disease. We don't offer or recommend vagotomy, but it's just the observation that they have found out. So that's the first stage, that people develop this protein in the gut, then through vagus nerve, it spreads up to the brain, to the lower part of brain, which modulate our sleep, and hence the act out dream episodes. Then the third stage is usually that factory, dopamine producing factories here in the midbrain. It affects those cells. Fourth stage, it goes to the limbic cortex, which regulates our mood, behavior, emotion. In fifth stage, it goes to the cortex. That's how people develop cognitive impairment. This is a hypothesis and work in progress, but it can explain a lot of those things. As I mentioned, Parkinson's disease is due to this missing chemical. We call it dopamine, and when the people get deficient with this protein, they develop tremor, stiffness, slowness, posture changes. But that's not the only chemical which is responsible for Parkinson's disease. Serotonin, acetylcholine, and noradrenaline, they are also the responsible agent there. This is the graph that how many people we have around the globe with Parkinson's disease. 6.2 million people with this disease. In 1990, the numbers were 3 million. So in 25 years, it doubled down to 6 million. And it's projected that in the next 25 years, it will be projected to, the number would rise up to almost 13 million. Why is that important? That, this staggering, alarming number, so that, we know what is causing that. You put some money in the research, and also find out how to manage this disease, and whether we will be equipped there. Because if we are struggling with the disease now, and if doubled down to 13 million, what would be our management plan? There are about 60 to 65,000 people who are diagnosed every year here in the United States with Parkinson's disease. This is a nice paper by Ray Dorsey and Bas Bloom, and they're calling it actually a pandemic. Pandemic is the word we use usually for infectious diseases, but why for Parkinson's disease is just these alarming number that it's a pandemic rather than something trivial. What are the responsible factors? Age. One of the things that we achieve, and one of the progress that we made over the last one century or 2 centuries, that people are living longer. So when people are living longer, they develop neurodegenerative diseases like Parkinson's disease, Alzheimer's disease. Second responsible factor could be industrial revolution. In the last 2 centuries, there is revolution going on in almost every industries. Example of those would be pesticides, insecticides, chemical that we use, all those things. What affects the quality of life more, motor or non-motor features? It's actually the non-motor features. And the reason is, we movement disorder specialists, we are well equipped with the therapies for movement disorder, the things that we see in clinic. But what about those non-motor symptoms, which the patient usually do not have insight, or the doctor just step over those things? These include GI symptoms, loss of appetite, nausea, vomiting, sometimes with the medication, sometimes due to slow stomach movement. Pain is a big feature. Sometimes we see it off when patients are getting off medication or wearing off. They experience pain. Different urological problem that Dr. Wakefield will go over. Cardiovascular blood pressure changes, drop in blood pressure, those kind of things. Sleep problem, fragmented sleep, frequent wakening. Then the REM behavior disorder, obstructive sleep apnea, apathy, cognitive problem. Dr. Shankar will discuss those issues. Numerous mood problems, psychiatric disorder, anxiety, panic attack, depression, those mood issues, respiratory problem, shortness of breath, and then weight changes. The natural course of this disease is people usually lose weight. And why is that? One is with the disease, sometimes those circuits, those cells are affected in hypothalamus, sometimes with the hypermetabolic activity, like they shake and usually lose calories. Genetic and environmental factors. One of the researchers mentioned that genetic loads the gun and environment pulls the trigger, and rightly mentioned, actually. These are some of the genes which we have found out so far, more than 20 genes. We usually do not offer the genetic testing. Why is that? Usually if it is 20 to 40 years old patient, if they develop with a strong family history, we can offer. But in a patient with 50, 60, 70-year-old, it's not just the genetics that's playing a role, environment also. or sometimes those genetic susceptibility. But let's say if we do those genetic testing, the management stays the same, right? So there is no need. We usually do not recommend those genetic testing. This is a typical garage. And exposure to a pesticide and solvent and risk of Parkinson's disease. This is a paper by Dr. Brown, and this is a meta-analysis. On the right side of the screen, you can see those dots means that there is correlation with pesticide and development of Parkinson's disease. Paraquat is an insecticide that is very strongly linked with Parkinson's disease. On the EPA website, mentioned that a teaspoon can kill you. But yet we are using this chemical. It's been banned in a lot of countries, Great Britain, but they are exporting it to America and Brazil. There is a petition going on at Michael J. Fox Foundation, and you guys can sign up for that, because we should stop those things which can damage our bodies. Intake of dairy foods and risk of Parkinson's disease. What could be the reason? The reason is cows eat contaminated grass sprayed with insecticide, and we utilize those dairy products, and we have found out that the level of insecticides is high in milk and also in patients with Parkinson's disease. But they are beneficial also, right? They are for bone health, and is a good ingredient. There vitamin D, calcium in there. So we are not recommending to stop those products, but just this is a link that we have found out. Same is true for viral hepatitis, hepatitis B, C, inflammatory bowel disease. If there is any statistician, they would know about the odds ratio. If it is above 1, means that there is a high odds of developing that result. There is a link between the offending agent and the outcome. So you guys can see that well water, herbicide, insecticide, trauma, and then actually cigarette smoking that I'll explain is protective. Smoking is protective, that I'll discuss in further slides. TBI and concussion, head injuries. Muhammad Ali, he was the prime example of that. Anne McKee from Boston University, she's working on those NFL players, whether there is a link between concussion and those post-concussion syndromes in those NFL players. And so far, those studies are showing us that, yeah, people who has head trauma, they develop those abnormal protein and some structural abnormality there. And same is true for Parkinson's disease too. Frozen addicts, anyone heard about those or read about those guys? These were the folks who were doing making meperidine in their basements. The formula went wrong, and they developed Parkinsonism. And now we have experimental model for that. What's the association between gut and brain? This is a nice study which was published last year. They injected those mice with those fecal matter and flora of Parkinson's disease, and they developed features of Parkinson. But there's just on animal, in animals that we found out that there is a relationship between the gut microbiota and Parkinson's disease. Agent Orange that was used in Vietnam War, and Later on, we found out that some of those folks, they develop Parkinson's disease. Other profession, increased risk of Parkinson's disease, welder, miners, farming. These three professions are linked with it. What could be the protective factors? Smoking, ibuprofen, caffeine, and high uric acid level. People have tried nicotine patches and others, but so far we do not have good results. We do not recommend smoking because you will get some other problems, COPD, cancers, and those other problems. But the thing that I think that is playing a role is that end of last century, there was, again, another revolution against smoking. Stop smoking, people are living longer, and when you are living longer, people develop Parkinson's disease or other neurodegenerative. So whether that is a factor involved, we do not know. I usually encourage my patient to drink at least 2 to 3 cups of coffee. It won't prevent it's not a therapy that it will treat your tremor or slowness, but at least you will be more awake. And coffee is good, right? There's a saying that it takes a village to manage a patient with Parkinson's disease. People usually think that it's just the doctor which will manage us, but it's not only doctor, but those other services also that are important. Physical therapist, occupational therapist, speech therapist, swallow evaluation, urologist, cognitive neurologist, neuropsychologist, and you name it. And what we have found out that if patient is managed in this way, in this multidisciplinary approach, they do well than just a doctor managing the problem. Does seeing a neurologist matter? This is just a neurologist, not even a movement disorder specialist. Yes, the answer is yes. It prevents fall, fractures, disabilities, and risk of hospitalization if a neurologist is managing your problem. In management, we look at the risk factor, medical treatment, neuroprotection, neurorestoration, neurorehab, exercises, DBS, surgery, pallidotomy. Michael J. Fox has pallidotomy, right? Not DBS surgery. Cell transplant, gene therapy, and then a huge list of complementary alternative medication. So we discussed that it's due to a missing chemical. So the management is just replace that chemical, right? So if you are deficient in dopamine, just replace that chemical. That include carbidopa, levodopa, a mouthful word. Levodopa is the active ingredient in it. Carbidopa is just to facilitate the transport into brain so that you don't develop nausea. Cinnamate immediate release, controlled release, Stalevo. It is combined with a different medication, entacapone. Ratari, which has been there with us for a couple of years. Parcopa is an orally dissolving medicine. If you are going for surgery or if you have difficulty swallowing, Parcopa is the medication that we use. And Dopa pump. Dopamine agonist, pramipexole, ropinirole, rotigotine, and apomorphine. Those subcutaneous injection, and there is a pump also in the pipeline. It will be there with us soon. Then these two groups are the enzyme inhibitor, the enzyme which is there to metabolize dopamine These include, so we inhibit that enzyme. It includes MAOB inhibitor, rasagiline, selagiline, and a new kid on block, safinamide. COMT inhibitor and entacapone, and the combination Stalevo is carbidopa, levodopa, and entacapone, and tolcapone, due to side effects, is not being used. Amantadine, immediate release, and now we have the controlled, the extended release also approved. And then some anticholinergic medication means trihexyphenidyl and cogentin. If you have tremor, which is really refractory to medication, sometimes we use this old medication, trihexyphenidyl. But then there are side effects with it. One of the most common one is memory problem. Carbidopa, levodopa is the most important one, and I know a lot of you being on this medication. It's a really good medication, and we proved that there is no toxicity to the brain from this medication. But there are a lot of myths outside about this medication. And I don't know who put it on Google, but there are that the medication is effective for 5 years. There's a myth. If your symptoms are responding to the medication, it will continue to respond. 5 years, 10 years, 20 years later, your tremor would respond. It's just that people develop new features like memory problem, mood problem, sleep issues, that this medication is not for those symptoms. And then people are under the impression that this medication is no longer working. So the dopa phobia was there in 1990, and this is a L-DOPA study that proved that medication is not toxic and it's effective, and that's how we've been using it. It's been there with us for more than 50 years. This is a very important slide, the motor fluctuation and dyskinesia. Initially, when you are diagnosed, everything is good, whether the doctor give you blue, white, red pill, all those medication works, and that's why this is called honeymoon period. But just like the typical honeymoon, it's a short lasting. And then people develop this, what we call motor fluctuation. So they develop this peak and value. Let's say if you were using the medication, it would last for 6, 7, 8 hours, 3 times a day, and it was working at that time. But then the window gets shrunken. You need more of that medication and at frequent interval, 4 hours, 3 hours, 2 hours. And that is what is called motor fluctuation. And if your doctor give you a little bit more of that medication, people develop dyskinesia, those abnormal movements. And less of that medication, they are then frozen, or they have those tremor, stiffness, all those features. So the therapeutic range lies somewhere there. And this is where comes the role of those longer-acting medication, whether it's a controlled release, extended release, Retari, Stalevo, or DBS, because DBS can plateau it out, those motor fluctuation and dyskinesia. Visual hallucination is a very important thing, and the reason that I put the CNN logo is that one of the medication that in April, there was a report that it leads to increased mortality, but this is a class effect, and I'll explain it why. Visual hallucination is very much underreported. Main things usually that we need to rule out are infection, UTI, and pneumonia. There are certain medication that if you are on those medication, we try to get rid of them. Artane, amantadine or those dopamine agonists. And then there are numerous medication that we can use, quetiapine or clozapine and this pimavanserin, Nuplazid. And as I mentioned, the black box warning is that old age, if you use this medication, it leads to cardiac problem and death, but it's a class effect. Means all the antipsychotic can cause that, and we usually discuss with our patient. Visual hallucination, they usually are benign mean. This is not a good term, but they don't interfere with patient lives. But if it is interfering with your life, we have medication, and we need to figure out if there are something else going on. Usually the most common one is that people feel the presence of other object or people or cats or dogs, that somebody is there in the room. But again, if it affects life, and it's one of the basic reasons that patients are usually placed in nursing home, but the caretaker also need to discuss it with the providers so that if there are any reversible things, we can fix that. Depression, I won't go in detail because Dr. Shankar would talk about that, but it's also very much underreported. People usually think that it's reactive one. Means they've been given this diagnosis and it's a reactive response to that. But it's actually endogenous, means part and parcel of the disease. Those circuits, those mood circuits are involved. Up to 60% of patients, 50-60%, so half of patients, they have mood problem, anxiety, depression, panic attacks. Dopamine agonist and impulse control disorder. What is impulse control disorders? This is when people do excessive shopping, gambling, binge eating, hobbyism, pornography, watching porn. And this is with those dopamine agonists, Requip, Merapex, and Nupropes, less as compared to those other two medications. Previously, the link was, the association was that 17% of patients, they develop this impulse control disorder. But now this French study came a few months ago, and the risk is 46%. So half of the patient, they can develop. And again, it's underreported. If you guys are involved in any of those things, you need to discuss with the provider, because the management is not that easy. If we get rid of that medication, people develop what is called dopamine agonist withdrawal syndrome. And this is when they have a lot of those anxiety, depression, suicidal ideation. So we need to slowly titrate it down. MOB inhibitor mean Azilect or Selagiline, and the risk of this dopamine, this serotonin syndrome. When we start you on this medication, usually the pharmacist raise flag, and they are like, we cannot combine it with the mood medication. But Azilect is 1 milligram daily, and Selagiline is 5 milligram twice daily, and at this dose, there is no risk. So there is no risk of this serotonin syndrome. At higher doses, then the MOB inhibitor, the B specificity is lost, and it can interact with a lot of other medication. But at this dose, the dose that we are prescribing, there is no risk. And this is the medication from MDS Society. A very important slide. People with Parkinson's disease sometimes get hospitalized. We have this bag, wear and care kit. They get hospitalized for falls, elective surgery, pneumonia, infection. But they get worse in hospital. And one of the reasons for that, and there is a study that 3 in 5 patients, their symptoms get worse. And the main reason is that a lot of providers, doctors, nurses, they don't know about those medication and Parkinson's disease and management. And people are taking those medication 5, 6, 7, 8 times in what their schedule, twice daily or maximum 3 times a day, those antibiotics that they give to patient. And plus, nurses are also busy taking care of 5, 6, 7 patients. And this is why you guys need to advocate for yourself. If you don't have this kit, this bag, it's available for National Parkinson Foundation, or you can ask Patsy or come to our clinic and we can provide it free. But in it, not only the bracelet, but the medication list is there, and you guys can educate the folks over there in hospital. It's okay, they can learn from you too. These are some of the issues, a very hard pill to swallow, but there is a time when you need to discuss it with your loved ones and also with your provider, driving, competence placement, and caregiver support that American Ingham will discuss. If you are on those medications that I just mentioned, carbidopa, levodopa, dopamine agonist, any of those medications, do not stop the medication abruptly, all of a sudden. Otherwise, you will end up in ICU. You will get very sick. If you are not happy with the medication, talk to your provider, and they will give you those titration schedule. Do not stop the medication. People develop this, what we call neuroleptic malignant syndrome. If you are not interested in those medication, a lot of people on coast, California, New York, they use a lot of those complementary and alternative medication. And, herbs, diet, organic diets, those other therapies, massage therapies, Tai Chi, exercises, and exercise has a huge role. People who do exercises in their 20s and 30s, less risk of developing Parkinson's disease later on. And there is some evidence that people who do exercises on a daily basis or 3 or 4 times a week, they can slow down the progress of this disease. It's controversial, but there's a fact. Deep brain stimulation. How many of you guys have DBS implantation? Raise hands. Okay. It's been approved in 1997 here in US, and it's a 2-stage surgery. One is putting the lead in there, putting a hole in the skull, and a lead implants this, and then the second stage is putting this battery in the chest and connecting it to those leads. There are 2 sites that we can do that. STN means subthalamic nucleus, and GPI, globus pallidus interna. And there are other locations also for freezing of gait, but those are under research. These are the folks who respond really well to deep brain stimulation surgery. You need to have Parkinson's disease rather than Parkinsonism. If you have Parkinson's disease, levodopa responsive, mean we give the medication, your symptom responds, you will respond to deep brain stimulation. Your symptoms will respond to deep brain stimulation. One of our mentor, Dr. Stanley Fan, rightly mentioned is electronic dopa. DBS is electronic dopa. Whatever symptoms respond to medication, rule of thumb is that those symptoms would respond to deep brain stimulation also. Those include motor fluctuation, dyskinesia, tremor, rigidity, bradykinesia. But if your doctor is discussing that option, you need to have realistic expectation. What does that mean? If your problem, your most bothersome symptoms is memory problem, mood problem, sleep problem, balance problem. DBS is not for that. Doctor is looking at tremor, and he can refer you for surgery, but that's not your big problem, right? So that's why it's really important just to write down every time you go to a doctor, write down what bothers you the most. We have knowledge, but that encounter is usually 20, 40 minutes, and you have to advocate for yourself that what bothers you so that your doctor can rightly manage that problem. If it is your symptoms are levodopa unresponsive, dementia, depression, psychosis, DBS is not for you. Age, there is no cutoff, but mine is usually 70 year, but again, 75-year-old cognitive star, I usually refer them for deep brain stimulation surgery. My time is up? Okay, I'll go over this. This is another one. Recently, this study has been published, neurostim studies that previously we used to say that it's for advanced Parkinson disease, but now 4 years into the disease, your doctor can consider that. These are some of the pumps. The one that is with us is the Duopa pump. It's called LCIG, levodopa carbidopa intestinal gel. Soon will be this pump also with us, subcutaneous apomorphine pump. These are some of the indication for Botox that we do, dystonia, drooling problem. Drug repurposing. Am I done, or I can talk? One minute. So I'll spend some time on this slide. FDA usually takes some time to approve medication. Sometimes 10 years, 20 years with $1 million. So what if we have the medication that are out there for this, the medication that we use for high blood pressure, diabetes? There is some role of those medication in Parkinson. This is a work in progress. Nilotinib is the one that I think last year or a couple of years ago in Daily Mail, there was this publication that they said that Parkinson victim brought back to life. And it was just a small study, and it's a chemotherapeutic agent, a cancer drug. We cannot prescribe a cancer medication for Parkinson disease until and unless we have evidence there. They were mentioning that, people who are wheelchair bound, they start walking, they start talking, but this turned out to be a hype. There is a study going on the same medication in George Washington University, and stay tuned for that. And it's not advancing. So. Yeah, maybe it's a sign. I think the next slide was stem cell tourism. Again, numerous studies has been going on. I shouldn't say numerous because next slide is, I was looking at, how many studies are going on, and there are actually few studies, very few studies. China, Australia, one here is finished, Dr. Singer, and we will look for the results on that study. The only benefit or problem that you can get is that you will be a bit less rich after this stem cell therapy. Otherwise, no positive results with us. Medical marijuana is the last one, but I think you guys have heard me giving a talk on this. Again, we cannot prescribe it because the data with us is limited. And this is the side effect list that I usually provide my patient, that it can cause more problem than sometimes the benefit for the patient. And then just please don't go to YouTube, because there are those anecdotal reports that, my tremor got better, but I have my patient who were using it end up being hospitalized with visual hallucinations. So it's not for everyone. But let's say if you are using it, discuss it with your provider. Thank you so much.